We all know that India is the highest estimated TB burden globally. TB infection, latent TB infection, globally highest. So nearly 35 to 40 crore of Indian population, they have latent TB infection. So out of which 26 lakhs they develop into active TB in India. So what is this latent TB? So latent TB is the presence of TB germs in layman word, TB germs, which is Mycobacterium tuberculosis in the body, which are dormant, asleep in the body. So these TB germs, they can remain dormant in our body for a long time, even decades also. So I'll come into that later. So what is the difference between the dormant and the latent TB or inactive TB and active TB? So latent TB or hidden TB or inactive TB, it has no symptoms. They have no symptoms. One. Number two is they cannot spread to others. Number three is even if we send do the X-ray also, the X-ray will be normal. If we test for sputum by microscopy, by CBNet, by TrueNet, the result will be negative. So in case of active TB patient, they have symptoms like what my colleagues has mentioned. The patient will have cough, the hemoptysis, the night sweat, fever, chest pain, fatigue, loss of weight, loss of appetite. Those symptoms they will have, and they will spread the infection to others. Active. And if you do the chest X-ray, the X-ray will show normal. If you do the microscopy or sputum test, it will show positive. So the difference between the inactive latent TB and the active TB is that which I mentioned just now. So can latent TB develop into active TB? Yes, because 5 to 10% of those infected with latent TB infection, they develop into active TB in the course of their lives. Usually, in the first 2 to 5 years of that initial infection, so it may develop. But the germs is in your body, but it is not developing. Why? As my colleagues has mentioned, it is because of the immune system. They are in the germ is in the dormant phase. It is because the immune system, the person's immune system is preventing the germ cell to grow, multiply, and develop into active TB. So it is the immune system only. So immune system it plays an important role, because immune system is a defense system. Our defense system only. Any kind of infection, disease, TB, maybe COVID or anything, our immune system is the one only that which prevents them to become active. So that is one. So how can we stop, or how can we prevent latent TB from becoming into active TB disease? So number one is by finding and treating latent TB infection amongst the that is number one, through active case finding amongst the high risk population. So that is extremely very important to end TB and also to achieve TB elimination. So the active case finding among the high risk population by treating and by finding and treating the latent TB infection. So to prevent to develop active TB disease, we give TB
Prevention
preventive.
is always better than cure, is the logic that this TPT is trying to emphasize upon. TB treatment is possible, but it's not very easy because the treatment drugs are a whole combination of 4 drugs. Even if we talk about the drug sensitive form of the TB, it's 4 drugs and it has side effects and some long-term treatments which are of the multi-drug resistant form of TB. It has even the capability, the potentiality to make the person go deaf also. So rather than undergoing through all those turmoil, why not we prevent the latent TB infection in the first place from progressing to the active form of TB by treating it? So that is where we are about the importance of TB preventive treatment. So what is TB preventive treatment? It is also a treatment through a certain duration of treatment course through different approach of treatment regimens. And of course it is also free. And the preference is also initially was given to the community of people living with WHO. The World Health Organization has come up with certain TPT treatment regimens. It's not only IPT for 6 months. In some countries, IPTs are being given for 9 months also. But more than that, the preference is a better short course regimen. So, not only IPT for 6 months, but now there are, I believe, 6 treatment regimens. But we will not discuss all those for today. What we'll discuss is the one which is made available in India in many parts of the state, and the one which our state will very soon have. They or me cannot commit when, but the drug has arrived in Nagaland. So now the modalities of how to make it operational will be worked out, of course, by the department, and then that new treatment regimen in the form of a shorter course regimen will be very soon rolled out. So we will be discussing on IPT only for today, and also the other regimen which I am referring right just now about what we will be having very soon is the treatment regimen called 3HP. Okay, 3HP. Now, what is 3HP? The 3 stands for 3 months treatment course. Okay, 3 stands for 3 months treatment course, and H stands for the acronym of the drug called isoniazid. So 3H and P stands for the name of another drug called rifampicin. Okay, so those drugs are being mentioned over there also. So we need not worry about the spelling or things like that for now. So 3HP is 3 months with isoniazid and rifampicin. So it's a combo drug now. So I will just give a comparison about IPT versus 3HP. Okay, so IPT is 1 drug with isoniazid for 6 months, whereas 3HP is 2 drugs with a treatment duration of 3 months. Okay, but in this, the 3 months treatment duration does not mean that it will be a daily medication. It will just be a 1 weekly dose, 1 single dose per week. So all in all, I'll just be slow here again. All in all, there are 4 weeks in a month. So every week, if I have to take 1 dose, it's 4 doses only in a month. Into 3 months means 12 doses only. Okay, so 12 doses. So here we have IPT, which is, I said, daily dose for average of 180 doses, as in days. Here we have 3 months course with a dose of only 12 weeks, as in one dose for 1 week, for 1 dose in a week. That means it's just 12 doses only. So this is 3HP is a shorter course regimen. So therefore, the argument is not condemning the IPT program for now, because that was the only option, and I believe that option also still should be made available. The people has to give informed, has to be given the proper knowledge and should be given the liberty to make informed consent and take informed decision whether they want to opt for the IPT program course or they want to opt for the 3HP program course. Because 3HP also comes with another drug, like I said, that rifampicin is there. And if we talk about rifampicin, this also is a TB treatment drugs only. And then, just like any other drugs, even paracetamol, for that matter, even the HIV treatment drugs, for that matter, just like any other drugs, these TB treatment drugs also has side effects. Therefore, these drugs that are used to treat the latent TB form of infection also has side effects. But those side effects usually outweighs the potential benefits, which means if someone don't undergo this treatment, fearing the side effect or fearing other reasons like distance or I don't want to go there or the social stigma that we have been discussing, because of all those, if anyone who is likely to be having the latent TB form of infection does not undergo either the IPT or the 3HP TB preventive treatment, then it's very likely that he or she might progress to the active form of TB within a month's time, within a couple of months, or even depending on the person, the immune response of the person. So those are the thoughts that is coming into my mind. Just to also bring a little bit about the reflection, who all are eligible for this. Now, like I said, out here 10 of us might be having. If we go to the old MLA junction, for example, for now, 200 people, just giving a very rough number, okay, 200 people might be just moving around. So out of those who may be having LTBA, we don't know. But who do we test? That also we don't know. Can we test everyone? That is not possible. Because testing is to do with some other medicalized form of lab investigation. So, and it's absolutely not very necessary to keep on testing everyone. So the program is now thinking on narrowing down its focus to a certain group of population, not randomly to everyone. Okay. Like the best example I could give, in fact, COVID has taught us a lot of things. The best example that we could interpret through this is the COVID experience, where the contact tracing word was used, right, in COVID. So if I'm with COVID, and he is my brother, she is my sister, we all stay together in this room. Then if I'm with COVID, then they are my contact tracing, so they undergo the COVID test, he also, she also will undergo the COVID test. That is what was done in the war against COVID. Similarly, in this war against TB, let me just use the word for now, war against TB elimination, if I'm with TB, then it's very likely that since we are staying together, they might have got the infection from me, like doctor mentioned that, through my droplets, because we interact with each other, we stay together under the same roof, eat, sleep, interact together. So if I'm with the active form of TB, my TB bacilli, the germ, might have been floating around in this room and he might have inhaled, she might have inhaled. So they are my, we don't use the word contact tracing out here, but they are my household contacts. HHC ko na household contacts. So they are my household contacts. So if I'm with active TB and undergoing the TB treatment, they might have got exposed to my TB germ. Therefore, they are my household contacts. So they will be given the IPT or the 3HP. Okay. So similarly, people with HIV, people with diabetes or any sort of cancer, any sort of immunosuppressed form of health condition are supposed to be given this TPT. whether it be IPT or 3HP. The program, of course, also has to focus on ruling out. This point is a little confusing, tricky. For anyone to be initiated on TPT, first, active TB has to be ruled out. Active TB has to be ruled out. Because if that is not done, then we will be giving the TB prevention treatment to someone who is already sick with the disease. So that is the wrong approach. So TB naik when I have confirmed again. TB has to be ruled out first. If in the process of the screening, if any sign and symptoms of TB has been found, has been detected, then that person might have to undergo the various diagnoses that has to happen, and following that, if found to be with TB, then the TB treatment should happen. So ruling out active TB is very important for anyone to be initiated upon on TB preventive treatment. How to rule out TB in anyone, in any person before initiating that TB preventive treatment is through the verbal screening. The program called it 4S, right? 4S. So if anyone who is a household contact exposure comes to the TB center, then the doctor or the nurse or the staff out there will interact, consult that person and assess whether he is having any sign of TB. As in, bukhar ase, kashi guri ase, night sweat, loss of weight ase, loss of appetite, all those questions. If any of those answers are yes, then likely TB may be there. But on the other hand, if those answers are all no, that person is not having fever, no cough, no night sweat, no loss of weight or loss of appetite, then TB is likely that it's not with him. Active TB is not with him. That means he can be initiated on either IPT or TB. Active TB is there. Before that, latent TB is there. Before the latent TB starts making you sick, why not treat it? That is the argument. That is the rationale behind TB preventive treatment. And where can it be treated is, of course, in the district TB centers, which are attached to the district hospitals. And who can be given is something that we have discussed. Children below 5 years of age, the household context, and anyone with immunosuppression form of health condition can be initiated on either IPT, but better advocacy needs to be emphasized on introducing the 3 months regimen of isoniazid and rifampicin, 3HP. That is something that I want to share out to all of you. Thank you.
Background, TB is the main killer because like whenever our immune system goes down, that means 90% of us will be TB. So like in order not to have this thing TB, we were put into this IPT. Now it's good news that for 3 months course, 3HP has come, so it will be very good for our community. But there is this thing also, side effect for this IPT. Especially I don't know for non-positive, but when it comes to positive cases, there will be some dizziness and then skin rashes. So like dizziness, it's okay. Like they will consult the doctor and then the doctor will continue and then it goes off. But when it comes to this thing, allergic, it's very, again they ask the patient to challenge again to take again, but it's becoming bad to worse when it comes to allergic. So they have to stop the IPT. And then sometimes because of bill burden, Bill Burton also, they on silly ground said itu kali itu mata kita pikai bola itu pun pikai something like that. Excuses are also there from our community. And like it doesn't mean that I have taken IPT and then I will not get TB. No. Even if I take IPT, I will get TB also. Especially for those, we have to term them as miscase and LFU. Miscase means those who have lost their medication, that means ERD drugs for 1 day to 3 months, we used to address them as miscase. And from 3 months onward, we used to term them as LFU, lost to follow-up. So like those people who are on ERD treatment and they have missed the drug and for 3, 4 months, 7, some of them even up to the 5, 6 years. When they come again, they have to retest all these things. So in some cases they have detected TB also. But when they have taken IPT, the result is good. Good in a sense like recovery is a little bit fast. All the people living with HIV to take IPT, because if you don't take IPT, that means one day it will be like you will not die of HIV, because our main killer is TB. So that is a request that I want to say to my fellow people living with HIV.